Our next speaker, Donna Ah Chee, and I have to give apologies for William Tilmouth, who was going to do the keynote address. But Donna is the CEO of the Central Australian Aboriginal Congress Corporation, which is the Aboriginal community-controlled primary healthcare services in Alice Springs. Congress employs around 300 staff delivering services including antenatal and postnatal care, early childhood development, chronic disease, social and emotional wellbeing, women's and men's health, and 55 place childcare centres, as well as auspicing 5 health clinics in Central Australia. Do you have a private life after all that, Donna? Donna has lived in Alice Springs for over 25 years and is married to a local Yanganjara Arrernte man, and together they have 3 children. She is a Bungalang woman from far north coast of New South Wales and has been actively involved in Aboriginal affairs for many years, especially in the areas of Aboriginal adult education and Aboriginal health. In June 2011, Donna took up the position of the CEO of the National Aboriginal Community Controlled Organisation, or NACCO, before returning to Congress in July 2012. Donna has convened the Workforce Working Party under the Aboriginal Health Forum and was the chairperson of the Central Australian Regional Indigenous Health Planning Committee, a member of the Northern Territory Child Protection External Monitoring Committee, and jointly headed up the Northern Territory Government's Alcohol Framework Project Team. She currently sits on the National Indigenous Drug and Alcohol Committee and has recently, as the Minister outlined, been appointed to the Northern Territory Government's Back on Track Task Force. At a local level, Donna represents Congress on the People's Alcohol Action Coalition. Please warmly join with me in welcoming Donna to the podium.
Thank you so much, Marion, for that warm welcome. And I must say this is an absolute privilege to be standing up here today sharing Congress's story on behalf of our chairman, Mr William Tilmouth, and our board as a whole. But before I begin, I'd like to acknowledge the Arrernte people, elders past and present, and their native title body, Liratipa. And also thank Amelia for her warm welcome to country, and also Andrew Japaljari Spencer for his blessing as well. I'd also like to acknowledge the Honourable Robin Lamley, the NT Minister for Health and Alcohol Rehabilitation, and also acknowledge that all the Congress staff who are here today to be part of this important celebration. I'd also like to take this opportunity to thank you, Marion, and Paddo, and AMSANT as a whole for inviting Congress to share our story with all of you today. I'll briefly talk about the key benefits of the Aboriginal community-controlled primary health care model by using the development of Congress as a case study, and I'll also highlight from about 1994 the policy work and advocacy of AMSANT and what work that's done to further develop Congress. So without AMSANT, Congress would not be where it is today, and it is also fair to say that without Congress, AMSANT would not have been able to get started in the way that it did. Both organisations have been integral to each other's development, and I think this will become clear through my presentation. On the 9th of June 1973, more than 100 Aboriginal people from all over Central Australia met in Alice Springs to discuss the poor living conditions and health problems. This meeting decided that an organisation should be established to fight for the improvements, and the Central Australian Aboriginal Congress, now known as Congress, was formed. A board of directors called a cabinet was elected from this meeting to take responsibility for establishing the organisation. Congress also had, as part of its structure, a council that included representatives from all the major bush communities. The Cabinet was responsible for running the running of the organisation in between council meetings. One of the first actions of Congress was to begin a tent program that rented out tarps for about 50 cents a week to people without shelter, as 1972 and 73 were very wet years. This early program developed into Tangagira. Excuse me, Maya. Developed into Tangagira Council. Thank you, Minister. And was a very clear expression of the action on what has become known as the social determinants of health. In 1974, the late Dr. Trevor Cutter came to Alice to work for Congress to assist in establishing a medical service. Initially, he worked from the back of a motor car, moving around the camps, seeing people as necessary, and letting people know that there was a new health service which Aboriginal people had set up. In July, the pickup service started. Then premises were found in Hartley Street, seen in the picture, that became the base for the health service. Congress employed the first doctors in Alice Springs to work outside of the hospital. When we talk about community control, we are talking about more than 40 years of Aboriginal people working to set up, develop and maintain a dynamic and vibrant organisation. This community-controlled organisation has changed the face of the National Aboriginal Health Policy and has led campaigns that mean that Aboriginal people are treated in this town vastly different than they were in our youth. These changes include the type of health services that we can now enjoy or expect to enjoy. The Aboriginal community set up Congress. It was not an act of government or any welfare agency. We controlled it from the beginning and still do. In some ways, we had no choice. Our health status was very poor, as you can see from the infant mortality rate and life expectancy figures in 1973 when Congress started. The mainstream health system had completely failed us. We had to do something new and different to get access to healthcare. We also had to take action on the broader social determinants of health, and Congress was the key organiser of the first land rights rally, pictured here as the newly formed organisation was clear about the connections between health, control, land, culture, employment, shelter, among other things, long before we started using the language of social determinants of health. In fact, the early years was a period of grassroots activism for health, with many public rallies and street marches to fight for our rights in many different areas. As things have improved, the need for this level of overt activism has declined, as we now work in partnership with all levels of government and have been able to get a level of resources that really make a difference to our health. However, there is still much more that needs to be done, especially in the areas of early childhood development, education, employment, housing and other social determinants of health beyond the health system. With the growing level of inequality that is now occurring in Australia, coupled with the lack of willingness to properly tax the billionaires and the more than 1 million millionaires in Australia, we may well be heading for a period where we need to return to grassroots community activism to achieve the changes that are needed for our people. The continued strong advocacy for Congress saw the organisation increase its services over time. One of the key, very earliest programs was the alcohol rehabilitation service known as the Congress Farm, which was on the site that became Kapu. Congress added the dental service, childcare and the Congress Looker Up by the Grandmother's Law. By 1989, when the service moved into the new building, there was about 120 staff. 1990 to 1995 were the really lean years, where there was little new funding for new services and programs. These were the years of the National Aboriginal Health Strategy and Adzick, and Congress was one of the first organisations in Australia to become aware that there were major problems, and in typical Congress fashion, also suggested major solutions, which I will discuss further. Congress was also instrumental in assisting many other Aboriginal communities to establish their own Aboriginal community-controlled health services in Central Australia and beyond. It is worth noting, though, however, that there has not been one new Aboriginal community-controlled health service established in Central Australia for more than 25 years. We've got something wrong in recent times. It seems the path that communities use to take has become too heavily regulated, bureaucratised and risk-averse, such that we have become somewhat crippled in the development of new Aboriginal health services. We need to get back to basics if we want to achieve more Aboriginal community-controlled health services in Central Australia. I now want to outline the way in which Congress worked at a national policy level to achieve the changes that were needed to improve Aboriginal health, starting with the development of the National Aboriginal Health Strategy Working Party final report known as a National Aboriginal Health Strategy, or the NAS. Congress worked closely with the then Director of Anningie Congress, Chris George, who was the NT-AMS representative on the Working Party in the development of NAS. The NAS outlined a way forward for Aboriginal health, built on the foundation of Aboriginal community-controlled comprehensive primary health care. The development of this important strategy was led by the Aboriginal community-controlled health sector. Its major recommendation was that every Aboriginal community throughout Australia should have its own Aboriginal community-controlled health service. In order to implement that NAS, the government agreed to the recommendations to establish a Council for Aboriginal Health, state and territory tripartite forums, a specialised health branch, the Office of Aboriginal Health, and to fund a national Aboriginal community-controlled health organisation, which became NACCHO. The Commonwealth Government allocated $232.2 million over 5 years to implement aspects of the strategy. Of the $232 million, 171 was allocated for housing and infrastructure, and only $47 million was allocated nationally for Aboriginal health services. The total allocation was far less than the $3 billion estimated as necessary for the full implementation of the NAS, and the states and territories were meant to match the Commonwealth Fund dollar for dollar. Of course, this never happened. The money allocated for health services was grossly inadequate, and Congress, along with most other Aboriginal community-controlled health services, did not grow in this era and had to submit every year through the Adzick Regional Council process for our core funding. In 1990, the Aboriginal and Torres Strait Islander Commission, Adzick, was established and assumed national responsibility for Indigenous health. In creating Adzick, the Commonwealth Government did not consider the NAS, and so there was no clear role delineation between the Council of Aboriginal Health, which was meant to be the peak body advising the Minister on Aboriginal health, made up of Aboriginal primary healthcare experts from the health sector, and the Adzick Commissioners. There was also nowhere near enough funding given to Adzick for Aboriginal health services, and there was a belief in this era, led by Dr. Peter Shergold, the head of Adzick, that health services did not make a difference, and that Aboriginal health would only improve by investing in housing and infrastructure alone. It was also the strong view of Adzick that it was the responsibility of the states and territories to fund primary healthcare services, and not Adzick or the Commonwealth Health Department. Meanwhile, the experience of Aboriginal health services on the ground was very different, as Congress in Alice and Anningie in Tennant Creek were very clear that health services did matter. The problem was that they were so poor at the time that our people were dying in hospital from serious misadventures, and something needed to be done. In 1990, Congress supported an approach to Elliot Johnson, the head of the Royal Commission into Aboriginal Deaths in Custody, to try to get this commission to shift its gaze onto the unexplained deaths occurring inside the Territory's public hospitals. To achieve this, a series of case studies were detailed, but these were not allowed to be admitted as evidence following an injunction taken out by the Northern Territory Government. Instead, many of these cases became coronial inquests, the most damning of which found that the doctor who was in charge of quality assurance at the Alice Springs Hospital at the time was professionally negligent in the tragic, preventable, premature death of an Aboriginal pregnant woman. These tragic cases led to the calls for Aboriginal Health Services and the Central Australian Rural Practitioners Association, CAAMA, for a public inquiry into the Central Australian health system. The result was an independent review conducted by Professor Charles Kerr from Sydney University, and the report detailed many of the serious failings in the health system at that time, and its first recommendation was that the Northern Territory Department of Health formally recognise the Aboriginal community-controlled health services were part of the health system, something that didn't occur until 1998. The need to include Aboriginal health services in joint planning processes with both Commonwealth and the Northern Territory governments was also recommended. This led to the establishment of the Central Australian Aboriginal Health Council, which was given secretariat support by Congress. This council only operated for a few years as government simply walked away from the meetings to escape the transparency and the accountability that was created, as there was no legally binding agreement between all parties. However, it was the forerunner of what was to become the Northern Territory Aboriginal Health Planning Forum, established through legally binding framework agreements, and through the process of joint planning, we have worked with the governments as partners and transformed the Northern Territory health system. In 1991, the Public Health Association of Australia Conference was a watershed moment in many ways for the acceptance of the critical role of Aboriginal community-controlled primary healthcare services within the Australia's public health community. It was the best attended PHA conference ever, with more than 800 participants. It addressed the key social determinants of health and is largely remembered for both the shower block song in Pitjantjatjara, encouraging good hygiene practices, and the anthem tune of Row, Row, Row Your Boat, which sang "Listen, listen, listen" to us. We've got something to say. Community control health is the only way. John Little, the Director of Congress at the time, gave a keynote address which clearly defined community control as an integrated entity that elected its own board, set its own priorities, held its own funds, employed its own multidisciplinary staff, had the right to hire and fire, and the right to make its own mistakes. Shane Houston, the former CEO of NAHO, gave a very prophetic keynote address where he predicted what would happen to Aboriginal community-controlled health services due to the fact that the government had created Adzick without listening to the views of Aboriginal people, and how it should be created and how it should relate to the health sector, drawing on the principles of the NARS. This was the beginning of an analysis that Congress would build on in the coming years. The Royal Commission into Aboriginal Deaths in Custody, which took a lot of evidence from Aboriginal community-controlled health services here in the NT, released its final report in 1991. Like many other Aboriginal health services, Congress predicted the key finding that Aboriginal people were healthier in jail than in the community, and the key concern was the poor health outside of the jail and the lack of access to good health care. Many recommendations became the mantra of Aboriginal health services, trying to effect much-needed reform in government policy at the time. Recommendation 192, shown here in full, was one such recommendation which has really stood the test of time. Like the NARS, There is a lot in this report that is still important in many ways. If you only ever read one part of the report, then it should be the chapter written by Professor Marcia Langton entitled "Too Much Sorry Business," which remains the best piece ever written that describes the devastation and trauma that alcohol is causing in many Aboriginal communities. Setting up a structure with this many people on it for the purpose of health planning was doomed by design, and it was not designed by Aboriginal people. Anyone who went to tripartite forum meetings would come away with the view that it was all too hard and it was not possible for one body to plan across all areas. It did not work, and government allowed it to fail. The 1994 evaluation of NARS showed that it was never implemented. The Commonwealth and the states could simply not agree and went their own ways, and the states never committed the funds that were needed to match the Commonwealth contribution, which in itself was never sufficient. In this era, Congress did not grow and had to apply every year for its core funding to Adzick. There were no 3-year funding agreements then, and much uncertainty from year to year, making it very difficult to attract and retain staff. Very few new Aboriginal health services were set up, as such services were not considered to be necessary to improve Aboriginal health. Probably the most destructive part of the Adzick era was the way in which Aboriginal organisations from different sectors were forced to compete with each other for inadequate health funding. This led to intersectorial conflict and destroyed the cohesive way that the organisations previously worked together through the combined Aboriginal organisations. This quote from John Little, who was both the CEO of Congress and the chair of the Alice Springs Adzick Regional Council at the time, tells the story very well. We need to go along and basically compete with every other person in our area. I think that the hardest part of all, where, say, the health priorities are lined up with, say, legal aid, our local radio station or our youth centre. Sometimes it's hard with this regional council process to be friend with everyone in a small town, because when you are at the negotiating table, you have to look after your own organisation or your interest. And sometimes that can create ill feeling. Everyone can blame the commissioners or the regional councillors when they don't receive funding for their projects, or funding goes in an opposite direction. It is all designed to take the heat off the minister and Adzick itself and point it at the blacks. We're blaming our own mob, and I think that's a brilliant strategy for the government to make us all fight ourselves. Congress was very aware of the failure to resource Aboriginal community-controlled health services in the years of the NARS from 1990 to 1994, and something had to change if Aboriginal health was going to improve. Therefore, in 1994, Congress, with the National Centre for Epidemiology and Population Health, produced the manuscript Beyond the Maze. This identified a number of major barriers to Aboriginal health improvement, which provided the basis for the recommendations for a new way forward for the administration of Aboriginal health. Pan Anderson, in her keynote address, will expand on this in more detail later today. Congress, AMSANT, Central Land Council, Cape York Land Council, the AMA and others campaigned for these reforms, all of which were implemented, although the pooled funding arrangements only really happened in the NT. Commonwealth health funding is now close to $1 billion recurrent, and access to MBS and PBS has been achieved. Planning forums throughout Australia have been established, and peak bodies such as AMSANT and NACHO have been funded. The impact of the transfer on access to increased funding has been very dramatic. In the year of the transfer in 1995, there was only $70 million available to fund Aboriginal primary health care, and there has been a continuing increase in this funding since then. In 2013-14, $160 million of health funds was transferred into PM&C, which has reduced the funds retained in the Indigenous and Rural Health Division, which has replaced OATSI, to around $940 million. Using Congress as an example, in Alice Springs, we receive about $3,200 per health service client for about $24 million per year in grant funding from the Indigenous Rural Health Division. In addition to this, we claim about $3 million per year from Medicare, and we access about $2 million through the PBS for essential medicines. This is a trebling of our funding since the Adzick era. All of this has only been possible because of the transfer. AMSANT have played a key role in creating the administrative arrangements that enables all of this to happen for Aboriginal health services on the ground. And services and programs to Aboriginal people across the NT have increased as a result. This is what the NT Aboriginal Health Planning System looks like. The Northern Territory Aboriginal Health Forum was established under the framework agreement between the Commonwealth Health Department, the Territory Health Department and AMSANT, which was signed in 1998. It is through the forum that collaborative needs-based planning has occurred to improve the health system throughout the NT. Under the Primary Healthcare Access Program, FECAP, the NT was divided up into 21 health zones based on geographic, cultural and social affiliations. Major planning studies were undertaken which provided data collected on these 5 criteria in each zone: per capita primary healthcare funding, population staffing ratios, existing health infrastructure, capacity to benefit and core functions of primary healthcare. There was a need for a completely new funding model that was based on both pooled funding as well as access to Medicare and MBS. This was made evident by the reality that the historical funding levels was not based on need, and there was little or no coordination between governments. For example, in Central Australia, there was one health zone where the Commonwealth spent nothing and the NT spent their lowest amount of $347 per person. This contrasted with another zone where they both spent their maximum amount, leading to more than $2,000 per person. There was large inequity between zones. The Commonwealth Government, at the suggestion of AMSANT, agreed to a new integrated funding model as part of the new Primary Healthcare Access Program. This required the pooled funding of all Commonwealth and Territory grant funds, as well as the access to MBS and PBS. This is still the current way in which Aboriginal health services are funded in the NT. In order to allocate the increased funds, there also needed to be a clearer idea of what services and programs should be funded in each health zone, and this is why the Northern Territory Aboriginal Health Forum developed the first and subsequent version of the core functions of primary health care. This was based on a document that Congress first published in 1998. There have been 3 iterations of the core functions of primary health care. The first in 2001 was used to drive the initial investment under the Primary Healthcare Access Program, leading to a $30 million new investment over 5 years between 2001 and 2006, which took the average investment from $600 per capita to $1,800. Version 2 in 2007 was based on a large, regional, successful remote Aboriginal community-controlled primary health care service at $2,700 per person. This was used to lobby for the new investment as part of the Expanded Health Service Delivery Initiative, ESD, which came with the Northern Territory emergency response in 2008, following extensive advocacy from AMSANT with the then Health Minister, Tony Abbott. This led to a $50 million new investment in return for identified core services and corresponding core indicators. This took the system up to the current average of $2,500 per capita. In 2011, a version 3 was developed, and this version is still yet to be implemented. In the 2011 version, there are 5 domain areas of comprehensive primary health care, under which there are more detailed descriptors of key services and programs. The key gap areas that have been addressed in this iteration are in early childhood, family support, alcohol and other drugs, and aged care and disability services. There's been a lot of new funding coming into the NT in these areas, but it has not been allocated into the core services and programs in a planned manner. Unfortunately, some of this investment is now being wasted. For the remainder of the presentation, I want to focus on the way all of these key policy reforms led by Congress and then AMSANT have enabled Congress to grow into one of the best examples of comprehensive primary health care anywhere in the world. The Congress Board has recently undergone some important changes to its constitution, which has created 3 specialist non-member director positions in primary health care, finance, governance and administration, and these positions are open to non-Aboriginal people. There are 6 elected positions that are Aboriginal identified, and this has greatly strengthened the governance of the organisation. At the same time, there has been an independent review of the organisation's management and administration structure and systems, and this has led to a new executive structure with a focus on the better integration of Alice Springs-based services and programs, which are now all contained within a new division. In addition to this, the new structure elevated both human resources and finance to be directly reporting to the CEO. Both the remote health and public health division were already directly under the CEO. This slide provides a bit more detail about the key program and service areas in the finance, human resources, public health and regional health services divisions. This is a breakdown of the core services and programs in our Alice Springs Health Services division, including the main clinic, which includes dental, and our pharmacy, the Alukra Women's Health Service, which includes the Olds Nurse Family Partnerships Program, in Ginja, Children's Services, which includes an 8-week intensive abecedarian program for children who are developmentally behind, which I will touch on later in our social and emotional wellbeing section. There are now well over 300 staff employed at Congress, with many new services and programs addressing the gap areas in the latest core services document. This growth in services and programs could not have occurred without the work that AMSANT has done in shaping the administrative arrangements for Aboriginal health. An effective peak body makes a difference to the services on the ground. There's been a steady increase in the number of unique clients coming to Congress each year, with more than 10,000 in 2013-14, of which more than 7,000 were permanent residents of Alice Springs and surrounding outstations, and about 3,000 were visitors from outside our health service delivery area. There's also been a steady increase in the total episodes of care over time, now reaching 124,000 in the last financial year. The growth in the direct provision of pharmacy services is real testament to the success of the Section 100 initiative, which again was a policy solution to the lack of access to essential medicines for Aboriginal people, advocated for by Congress and AMSANT and introduced in 1998. Congress is accessing close to $3 million per year in PBS medicines, and there can be no doubt that if medical care is to make a difference in people's lives, then medicines must be accessed and taken. In the next few slides, I want to briefly highlight some of the important work that Congress has been able to do on the key social determinants of health, including early childhood, alcohol and tobacco. The health transition that has occurred has meant that the challenge has moved from the high death rate of babies and children to the promotion of healthy development. Much of the trauma and harm caused by adverse social determinants are mediated to children through lack of responsive care and stimulation from parents in early childhood, and this in turn leads to children who grow up more prone to both physical and mental health problems, including addictions to fat, sugar, alcohol and other drugs. The Australian Early Development Index has revealed the extent of this disadvantage that Aboriginal children have in language and cognitive domains, as well as the emotional domain when they first enter school. The next generation of young people who are likely to be impulsive, have unhealthy brain development leading to poor school performance, develop alcohol and other drug addictions, be violent on the streets and incarcerated are already there. We must do better at preventing this from occurring and early childhood is the key. Congress now offers some key social and preventative programs in the area of early childhood, which is arguably the most critical area that needs to be focused on to address intergenerational disadvantage. Children who are identified with developmental delays through routine health checks at age 3 are given an intensive 7-week program based on the Abecedarian program. Here is the data from 7 children who went through this program, which shows that they all improved their vocabulary by an average of 6 months based on the Peabody tests. This demonstrates that even at this relatively late age for children who have been understimulated, there is potential for rapid improvement prior to school. Most importantly, children's experience rapid improvement in development outcomes post-enrolment in preschool with age-equivalent vocabulary, which is one of the most sensitive measures of cognitive development. At baseline, 52 children with an average age of about 48 months are well behind in their language development, but they make very rapid progress once connected with preschool. As a result, these children will be much more school ready and be able to understand what is being said to them in the classroom. This becomes a bottom-up pathway to better school retention, as these children are more likely to want to be at school. Preschool needs to be available for all 3-year-olds as well. This slide shows the outcome of the advocacy that Congress has led through the People's Alcohol Coalition to increase the minimum price of alcohol. In 2006, when the Alice Springs Liquor Supply Plan was introduced, shown on the top of the graph as LSP, the minimum price of alcohol doubled from 25 cents to 50 cents per standard drink, shown by the sharp increase in the red line. The effect was nearly 20% decrease in per capita alcohol consumption, shown by the black line in the graph, which meant that about 120 hospital admissions for Aboriginal women for assault were prevented each year. This graph shows that there is a correlation between the decline in alcohol consumption, which came about with the introduction of the alcohol restrictions on October 1, 2006, and hospital admissions for Aboriginal women for assault. The blue line is the projected rate if the trend prior to the introduction of the restrictions had have continued, and the red line is what actually happened after the restrictions were introduced, a very significant change. This is a very objective indicator of the severe violence towards women as a result of the alcohol restrictions. Similar data is available for the impact of the former banned drinkers register and for the current very effective temporary beat location strategy. All of these strategies impact on reducing violence and promoting more healthy development for our children. Congress has been part of an advocacy for a whole range of measures to reduce smoking prevalence, including increasing the price through taxation, banning smoking in restaurants and other public settings, including in the Congress workplace, plain packaging, ensuring access to free nicotine replacement therapy, which has now been listed on Section 100, and implementing a social marketing and community-based health promotion program employing Aboriginal people as healthy lifestyle workers. All of this has seen smoking prevalence decrease from 58% to 48% over 4 years in Alice Springs. All of the complex activities of Congress can be summarised in this program logic for Congress using a template developed in a joint research project with Flinders University, Southgate Institute. Comprehensive primary health care is all of this combined. We have circled the mechanism around promoting economic policies consistent with public health, because this was a key part of the original Alma Ata Declaration on comprehensive primary health care. Economic policies with concepts such as deregulation and competitive tendering are often not consistent with promoting public health, and there are many examples of Congress advocacy where we are working to promote regulation, such as alcohol supply reduction, and a glucose tax, as well as needs-based planning, rather than competitive tendering. This is all part of the primary health care. This is all part of primary health care, along with a mix and range of services and programs. Congress is really one of the best examples in the world of a comprehensive primary health care service, and we would not have been able to get to where we are today without the support and advocacy of AMSANT. Finally, I want to finish with a few slides on the health gains that have been achieved. This graph from the COAG Indigenous Reform Council report shows clearly that the Aboriginal health gains in the NT are far greater than those occurring for Aboriginal people in other jurisdictions. Over this brief 3-year period, the life expectancy gains for Aboriginal males has been 2.3 years and for women 2.1 years. This is one of the most rapid health transitions occurring anywhere in the world, although the latest report suggests that these gains have now plateaued. While disappointing, this is not unexpected at Congress, as Congress and AMSANT have always argued that improving the health system alone will only address about a third of the gap, and this is what has been achieved in the NT up to now. If we are going to progress from here, it will primarily be due to improved educational outcomes, leading to secure, high-income employment, greater control for our people, and the key to this is early childhood. The steep socio-economic gradient in both mortality and morbidity in the NT reveals the challenges that lie ahead for all of our services and for Australia as a whole. If socio-economic inequality continues to grow across the nation, then the gap for Aboriginal people will not be closed. As I said earlier, if governments don't act to reverse this disturbing trend, then we will need to get back on the streets with allies in the struggle for health and social justice. Let's hope that this will not be necessary. This slide is courtesy of the presentation given a few months ago by Dr. Stephen Guthridge, a senior epidemiologist who is the head of the NT Health Department's Health Gains Unit, to the Northern Territory Aboriginal Health Forum. It both highlights the success of the health system improvements, as I've outlined, as well as the key challenges that lie ahead. Aboriginal people are no longer dying as babies, but are surviving into their middle ages and beyond. However, our people have a very high burden of illness and are heavily reliant on the health system to stay alive. We must do better in the primary prevention of disease, and this will require action in early childhood and actions to create a more healthy, promoting environment, including on the social and economic inequality. These are the best projections of where we are going as many more of our people live into the middle and older ages. This is good news indeed, but we also want our people to be well and have good quality of life at the same time. This is not too much to hope for, and if we have to achieve this, we need comprehensive Aboriginal community-controlled primary healthcare services now more than ever. Thank you.